Well, good afternoon, everyone, and thank you for the kind invitation. Now, we're all used to this environment. No? We're used to have an ICU patient surrounded by monitors, by beeps, alarming beeps, by pumps, by mess of cables, and to be able to provide the best possible medicine that we know. We're used as physicians to integrate all this information in a go. But sometimes maybe all this information can end up overloading ourselves. ICU caregivers are highly susceptible to suffer burnout. Probably you all know about this. And it, apart from affecting our well-being, it also affects the care we can give our patients. So maybe in this stressful situation, CDSs could be one of the solutions to help us. But what exactly are CDSs, or what exactly are clinical decision support systems? Well, there are many definitions. One of them is that a CDS is a process for enhancing health-related decisions and actions with organized clinical knowledge to improve healthcare delivery. In our environment, it can be defined as health information technology that builds upon the foundation of an electronic health record system to provide professionals with specific, filtered, and organized information. So, in other words, it's addressing challenges of big data to help clinicians make good decisions. When we talk about clinical decision support systems, we have 5 rights that we have to take into account. We have to deliver the right evidence-based information to the right people or professionals in the right format, through the right channels, and at the right time. And why do we need them? Why do we need clinical decision systems? Well, we're all witnesses to the exponential increase of knowledge, to the large amounts of clinical data. We usually face complex situations with small response time, and we're usually working in high technology ICUs where alert fatigue poses a challenge. So as physicians dedicated to intensive care patients, we monitor impact, we get feedback, and we respond. So, as you all know, electronic devices have pros and cons. Regarding the pros or the advantages, we're all used to have complex dynamic ICUs, change of patients, and a clinical decision system must anticipate needs and deliver in real time. They also help us to adhere to practical clinical guidelines. In this case, you all know the 2016 LungSafe study, where they published data that probably tell us that we were not doing the things correctly regarding ventilation of ARDS patients. Mean tidal volume ended up being like 7.6 milliliters per kilo. Plateau pressure measured was in around 40% of the cases. Prone position was only performed in 16% of the patients, and neuromuscular blockade in around 40%. And maybe that could be an explanation into why the APRONET paper published this year showed an increase, a 2-fold increase in the rate of prone positioning. And lastly, clinical decision support systems also helps us to provide our patients the best possible safe medicine and to be able to be at the bedside constantly. But there are also disadvantages, as you all know. Especially the mess of cables. No, I mean, clinical decision systems or electronic new devices must keep it simple. Simple interventions work best. We have to keep the algorithms, the knowledge base, and the interface as easy as possible to be able to work and to avoid interruptions on our usual workflow. So, having given a small introduction of what is a clinical decision system support, we would like to share our experience. In the first place, we would like to bring one of the projects my team has been working in for around 10 years, which we've called, it's a translation, in ICU Without Walls project. In this case, this project consists of the application of a computer system and algorithm for monitoring vital signs of patients admitted to the hospital, wherever they are, in the emergency department, in the hospital wards. And it allows us to have an early identification of deterioration, enabling rapid targeted management, and helps to reduce need to transfer for higher acuity units, reduce hospital lengths of stay and costs, and improve survival rates. And we thought about this because ICU physicians face new needs. And you probably, most of us are in one of these, no? There's an increased need of intensive care unit beds. We want to avoid unscheduled readmission or delay of admission of critical ill patients. We'd like to follow up fragile patients like high-risk patients or ICU patients upon discharge. We also want a multidisciplinary approach involving professionals from different medical specialties. And it's also very important to try to keep medicine focused on the patient and on the family. But to be able to do this project, or to perform the project, we have to change our mentality. We have to change from a closed-door ICU, where we only act when we are summoned or called, to an open ICU, or an ICU without walls, where we are using a computer alert system, and which is able to outreach all the patients that are within the hospital wards. And using this computer alert system, we activate our rapid response team, which will be able to help that patient. And also we use this computer alert system to keep under our eyes our ICU discharged patients. Now, this computer alert system that we use in this project consists of analyzing data from two blocks. On one side, we use our laboratory data talking about troponin, pH, PCO2, creatinine, lactate, C-reactive protein, and positive blood cultures. And we also use clinical data using an adapted early warning score for our hospital. And we integrate all this information. And we design an algorithm with which we act and we follow up all the patients that are around the hospital. So in this case, we usually use the vital signs taken every 8 hours using an early warning score. And depending on the degree of alteration of these vital signs, the on-call physician is called, or instead is directly ourselves acting there. After 10 years of using this computer alert system, we're really happy because we've presented outstanding data. We've managed to decrease in-hospital mortality, and we've managed to decrease in-hospital cardiac arrests. And as well, we've managed to change workflow and shift the most important or the heaviest work to the morning and the afternoon shifts and avoid the night ones. And we've managed to decrease weekend effect. Now, more of a recent experience, we've been using clinical decision support systems for mechanical ventilation settings. Now, as you all know, mechanical ventilation is life-saving, but if we use improper figures or improper settings for our patients, there's a risk for inducing lung injury, and there's a risk for producing the patient distress. So CDSs for mechanical ventilation settings are really a field to work in. And there's been a very important progress in it. In this case, we bring here the Islami paper published in 2009, where they used a very simple mechanical ventilation setting CDS system, where it was a little window that appeared in the ventilator recommending the tidal volume of a patient. But there's been an enormous progress in this area, and we've shifted from simple CDSs to more complicated open-loop physiologic-based models where we use individual data. Well, the system uses individual data and tunes the model according to the data obtained. Now, in this case, we bring on the screen one of the CDS for mechanical ventilator settings that we've been using recently in our unit, which is called the Beacon Care System. I'm going to talk a little bit about it, but not too much, because Professor Volta's talk next will be a little bit more detailed. So Beacon Care System or other mechanical ventilator settings uses information provided by blood gas sample, a gas analyzer placed at the end of the endotracheal tube, pulse oximetry, and data provided by the invasive mechanical ventilation. And after integrating all this information, it provides and gives recommendations regarding ventilation of the patient, gas exchange, lung mechanics, respiratory drive, metabolism, and acid-base status. And it uses a very friendly and simple interface that it helps us to understand the physiological changes behind our patient, and provides information in this type of screen and also in a nice hexagon that after Professor Volta will talk about it a little bit more. But where the CDS integrates information provided by oxygen with the risk of lung trauma and acidosis after analyzing pressure, volume, and frequency and support. Now, Beacon Care System connects with several different types of ventilators, Trager, Maca, Puritan, Bennett, etc. And it gives recommendations regarding pressure controlled, volume controlled, and pressure support modes. And we're actually working now with them in trying to design the algorithms to be able to receive recommendation regarding the proportional assist ventilation. Now, lastly but not least, we would like to bring here the future, or what we think could be the future, which is the multimodal clinical decision system supports. Now, we call it multimodal because it integrates information provided by different places. It integrates information from the bedside devices, from wireless devices, and from third-party devices, and uploads all the information on a platform where we can reach from a remote monitoring, and also integrates information regarding electronic medical records, clinical reports, and alarm forwarding. Now, the interface of vital sign monitoring, which is this type of multimodal CDS that we've been using, is very simple, and I'm trying to explain now. So we've got here the interface of Vital Sync, where we've selected as a physician those patients where I would like to keep an eye on, because I'm not probably very happy on how they're progressing. And Vital Sync allows us to have different types of monitoring for the patient depending on the severity of his situation. So Vital Sync uses early warning scores, like the box you have over there in yellow. Also allows us to keep an eye on basic monitoring, for example, placed in patients in the hospital wards using capnography on nasal prongs and trying to measure oxygen saturation, heart rate, respiratory rate. But it also integrates patients that need advanced monitoring, for example, our ICU patients, in this case, the ones with the blue box, where they've got 2 patients with a spontaneous breathing trial outcome, and 2 of them have finished the trial. So maybe Vital Sync is telling us you should go and see how the patient is going, maybe assess if he needs extubation. Vital Sync also has special apps that we are going to start to use actually now. So this is new for us. And there's 2 monitoring apps, one about weaning readiness and the other about spontaneous breathing trial monitoring, that we will begin to use now and see if we can improve our weaning protocol that we have actually at our hospital. Now, to the end, we would like just a word of caution as a team that's been using during 10 years clinical decision systems. We would like to say that CDS is what we think as a team that does not substitute clinical judgment for the moment. What we think is CDSs help us to try and understand the physiology behind our patients, helps us to understand how he's going, and probably helps us to make decisions. But CDSs should be used along with education, along with training, along with expert knowledge. And probably CDSs could be used, probably CDSs could be used in overloaded units. But there's still things to see and things to think about, because we have to define cutoffs. We have to define which patients would be best for the CDSs to use. And we have to think how we can combine the variables and be able to have the best response, without forgetting adapting the new CDSs that will come along to our local patient case mix, to our staff skills, to our training, and to our institutional capability. Thank you very much.